Oh, great, great. All right, so let's go to introduction. Blood transfusion ICU. Very briefly, blood transfusion is common in the ICU. I did a study in 2014 at the University of Benin Teaching Hospital, where we found out that about 30% of patients admitted in our general ICU received blood transfusion. 83% of them had 1 to 3 units of blood, and patients from obstetrics and neurosurgery had more blood transfusion than others. And we found out that although blood transfusion did not have any significant impact on patients' length of stay in the unit and mortality, the numbers of units of blood transfused appear to have been associated with poor outcomes. So the more blood units a patient received, the more likelihood the patient had poor outcome, with a p-value of 0.006. This study was published in 2014 in the East African Medical Journal. And this finding collaborates with many other studies that talked about how common blood transfusion is in the ICU. So remind ourselves about physiology of blood. We have plasma and cells. The red blood cells are optimized for gas exchange, and they have a lifespan of about 120 days. We won't go long on that because just to remind ourselves, the leukocytes, white blood cells, are crucial for immune response, and they have a lifespan that can vary from hours to years. And we have neutrophils, eosinophils, and basophils, the lymphocytes, and the monocytes. Just a reminder, we will not dwell on that. Platelets are important, especially for coagulation purposes, hemostasis, and they can circulate in blood for about 7 to 10 days. Their production is under the regulation of thrombopoietin, which is produced mainly in the liver. All right, plasma is the liquid component of blood, which comprises about 55% of its volume. All right, it serves as a means of transporting cells and various substances, and is very key in maintaining non-material blood pressure and volume, also as well as in coagulation. And this is important, especially when we begin to talk about fresh frozen plasma as a role in coagulation and in the management of coagulopathy. All right, so let's remind ourselves about blood products. There are different blood products. The packed red cells, these are made by removing most of the plasma from the whole blood. All right, and they're usually used to treat symptomatic anemia and in cases where you have significant blood loss to improve the oxygen carrying capacity of the blood. Typically, they're transfused about 1 to 2 hours per unit, and you need to be careful with the transfusion reactions with these patients. All right, first frozen plasma, I mentioned that before. We'll just go ahead. Platelets, we mentioned this before. So, yeah, let's talk about hemostasis and coagulation. All right, when a blood vessel gets damaged, either from vein puncture or by trauma or even surgically, we have three different levels of hemostatic mechanism. The primary one is there will be vasoconstriction of the damaged blood vessels, and this is aimed to reduce further blood flow. There will be platelet adhesion to the damaged endothelium, and this is mediated by von Willebrand factor. And we'll come to that because desmopressin is usually used for in cases of coagulopathy, and the idea is to increase von Willebrand factor. So platelet activation aggregation releases granules and that require additional platelets to form the temporary platelet block to secure hemostasis initially. The secondary hemostasis is when you have your coagulation cascade, which is a series of enzymatic reactions which lead to the formation of fibrin from fibrinogen. This stabilizes the platelet block that has been formed initially. And we have three different pathways. And the important thing is that if we look at the next slide, you will see the coagulation cascade. And the reason I brought this here is that the different coagulation studies, especially your prothrombin and your activated partial thromboplastin time, look at different parts of the coagulation cascade. Prothrombin time looks at the extrinsic pathway, while the activated partial thromboplastin time looks at the intrinsic pathway. Okay, and this is important, especially when you want to decipher the cause or the factor deficiency responsible for your bleeding. All right, so coagulation studies, we have different types. The platelet count, normal range is about 150 to 450,000 platelets per microliter of blood. Prothrombin time, like I mentioned, assesses the extrinsic and common coagulation pathways. And international normalized ratio that we normally use for anticoagulation therapy standardizes prothrombin results, all right, and is also very crucial. Normal range is about 0.8 to 1.1. All right, APTT assesses the intrinsic and common pathway. It's about 25 to 35 seconds. Fibrinogen level is important because the lower ones, and this is also used as a scoring system for your DIC. Your D dimer indicates the degree of degradation of fibrin. All right, and this is to restore normal blood flow in the circulation. So higher D dimer is a replication or is an indices of increased thrombosis. All right, so let's go to the crux of the matter: anemia in critically ill patients. Approximately, studies have shown that approximately two-thirds, 60% of all patients admitted to the ICU come down with anemia, even on the day of admission. All right, so they have a hemoglobin concentration less than 12 grams per DL. And 97% of these patients become anemic after a week in the ICU. Already, if we do that study, we realize that many of them, and this was reported by Thomas et al. And published in the Heart Lung Journal in 2010. And this has actually been collaborated by different studies. So anemia practically is common with critically ill patients. All right. So because of the way it is common, there's a term we now call critical illness related anemia. All right. It's characterized. The characteristics looks more like anemia of chronic disorders. All right. And the clinical picture of the laboratory picture you will see, we see IRA, critical illness related anemia, is that there will be reduction in iron levels in plasma. And that's why some authors, some clinicians want to supplement iron in all ICU patients because they have reduced iron levels in plasma. There's also reduced transferrin levels, although there's increase in ferritin and iron in sequestration in red blood cell. All right, and we're going to look some of these things as we go on. But importantly, I need to say that blood loss from phlebotomy contributes significantly to anemia of critical illness. All right, and a lot of times we need to weigh the benefits versus the risk of anemia in collecting blood samples for our patients. And some of the ways we're going to look at them in correcting anemia of critical illness is how to reduce blood loss from phlebotomy. All right, as my practice is, so I've tried to help you create a mnemonics. So if you're asked what are the common causes of anemia in critically ill patients, just write anemia and you begin to fill in the gaps. All right, so ADS starts about acute blood loss. Like I mentioned, about 40 to 70 mils of blood is taken from each patient on a daily basis. All right, for phlebotomy, either for ABG analysis or for complete blood picture and all that. Other causes of blood loss: trauma, surgery, GI bleeding. and its nutritional deficiencies, because most of these patients have reduced nutritional intake, or most of their feed low in iron, vitamin B12, or folate. All right, so this can cause anemia, and this is one of the reasons why some clinicians like to support or supplement patients that have vitamin B12. Abnormal coagulation, which can result from sepsis syndrome, thrombocytopenia, liver disease, and what have you. And erythropoietin deficiency, this could be secondary to reduced renal functions, or it could also be due to inflammatory cytokines circulating in the blood. Bone marrow suppression resulting from chemotherapy. Remember our clinical scenarios, we did mention that this patient had breast cancer and she was undergoing chemotherapy. Inflammation and infections of any sort, all right, can actually lead to anemia in the unit. Autoimmune disorders, all right, with your immune cells attacking the patient's cells can cause breakdown, and this will lead to anemia. So the common causes of anemia in ICU to remember. So the issue about anemia, why are we worried about anemia? All right, it has to do with systemic oxygenation and tissue perfusion. All right, if you remember oxygen transport and lectures on oxygen transport, you know that oxygen uptake is actually oxygen uptake by tissues is equal to the oxygen that's delivered, plus the ability of the tissues to extract the oxygen is delivered to them. All right. In anemia, the oxygen delivery is low because you have reduced hemoglobin, red cells. All right. Why oxygen extraction increases. All right. So at this moment, there's constant oxygen uptake, because while oxygen delivery is low in anemia, the tissues have adapted to extracting more oxygen. All right. And the decrease in hemoglobin concentration in anemia is also compensated for by an increase in cardiac output. So at the end of the day, your oxygen delivery may be low, but the oxygen extraction is optimized. So it's been found out that hemoglobin concentration about as low as 5 grams per DL does not have significant effect on tissue oxygenation. And this has actually challenged our long held beliefs, and I'm going to come to that. All right. So, based on this understanding, we need to now define at what level should we transfuse our patients, especially with red cells. All right. And transfusion trigger is defined as the point where anemia begins to threaten tissue oxygenation, leading to systemic hypoperfusion. So this decision or deciding about transfusion trigger should be a balance between the risk of blood transfusion and the risk of low HB. All right. Commonly, we remember the 1030 rule, which dates as far back as 1942, where it was generally believed and heard that patients' hemoglobin should be optimized to 10 grams per DL. That is a PCV of 30%. All right. Different studies have proven that hemoglobin as low as 7 grams per DL is considered safe for most of our patients in the ICU. All right, except in cases where you have acute coronary syndrome and severe sepsis, where there's increased oxygen demand and consumption. All right. Now, instead of using hemoglobin as a marker for transfusion trigger, a lot of other stuffs have come in, especially considering oxygen extraction as a better parameter for deciding your transfusion trigger. All right. So normally oxygen extraction is about 25 to 30%. All right. The oxygen delivered to tissue is about 100%, or around 100 mil, all right, per minute. But the oxygen extracted is just about 25 to 30%. So when you have an oxygen extraction of about 50% and above, it shows there is evidence of threatened tissue oxygenation, and this is when transfusion should actually take place, instead of just focusing on absolute hemoglobin value. All right, we'll come to that. Let's go to the trick trial, all right, which talked about the rational use of blood, looking at restrictive and liberal transfusion strategies. The trick trial, which was published in the New England Journal of Medicine as far back as 1998. All right, the trick trial is the transfusion requirements in critical care. All right, this was done by Herbert et al. And the aim of this trial was to determine whether a restrictive transfusion strategy, all right, aiming to transfuse only when HB is 7 gram per DL or below, all right, compared to the traditional liberal transfusion where the threshold for transfusion is HB of 10 grams. All right, it was a well-powered, studied, randomized control trial and took place in different multiple ICUs. About 838 critically ill patients were recruited for the study into two groups. We have the restrictive transfusion group, that is, you only transfuse if the HB is less than 7, and the liberal transfusion group, you transfuse when the patient's HB is less than 10 grams per DL. All right, so the trial demonstrated and concluded that the restricted transfusion strategy is as safe, is as effective and safe as liberal transfusion strategy. In actual sense, it showed that patients in the restrictive transfusion group have better outcome in terms of fewer blood transfusion and lower risk of transfusion-related complications. It was this study that actually popularized the use of restrictive blood transfusion in critically ill patients. So we'll look at red blood cell transfusion particularly, all right? And red cell is actually 1 unit of packed cells containing about 200 ml of red cells plus 50 or 100 ml of plasma, and with a very high hematocrit of about 60 to 80%. All right, packed cells are normally refrigerated at 126 degrees Celsius with a half-life of about 35 days. And this is very important when you compare with your platelets that are stored at room air. And that makes platelets more conducive for bacterial growth. So bacterial infection, sepsis, is commoner with platelet transfusion compared to packed red cells. And the difference is because of their storage properties. Packed cells are refrigerated at 1 to 6 degrees Celsius compared to platelets that are stored at room air. All right, so there are two types of red cells, and this is important for us to remember because your adverse reactions and to red blood cell depends on the quantity of white blood cells that are in your red blood cells. So we have two types. The idea is to have as low white blood cells as possible in your red cells. So we have the leukocyte poor red cells, which results from removal of white blood cell from plasma. And if you are able to remove about 50 or so percent of white blood cell from your blood when you are getting red cells, it can prevent transfusion-related non-hemolytic fever. All right, red blood cells can also be washed in isotonic saline, removing plasma and white blood cells. And this also has been found to reduce the risk of transfusion-related urticaria or anaphylaxis. All right, so blood cells that are stored, all right, we said that they have a shelf life of about 35 days, all right, but the longer the storage days, the level of your 2,3-DBG decreases by almost about 90% over 3 weeks. But the good news is that once the red blood cells are transfused into the patient, these cells are able to regenerate 2,3-DBG within 24 hours post-transfusion. Another adverse effect of stored blood is the risk of acidosis. All right, so prolonged storage is associated with increased acidosis and hyperkalemia. All right, know that the volume of plasma in packed cells, that is less than 100, results in little or no impact in the problems with stored blood. So, what is the response? All right, a lot of times we're bothered more with increase in hemoglobin concentration on your hematocrit, but in actual sense, oxygen, the effect of transmission of oxygen transport is that there's an increase in oxygen delivery, but not in oxygen extraction. And that's what we're saying, that the transfusion trigger should actually be the degree or the amount of oxygen that is extracted, all right, by the tissues. In actual sense, it's been found out that oxygen extraction may actually be lower following blood transfusion. It's just like somebody who is full and you're giving him food, he will have little or no appetite to eat your food, no matter how delicious it is. So there's actually a reduction in oxygen extraction in response to your red blood cell transfusion. All right, so this dogma, we heard this dogma a long time. The American Red Cross Society has this slogan that says, blood saves lives. Can I ask you, is this true of us? All right. Now we need to know that this is not true. We need to challenge this. Is it blood cells that save lives or blood volume? All right. Note that the important thing is restoration of intravascular volume. All right, and not supply of red cells. And the evidence stems from these 2 points I wrote here below. We know that hypovolemia is a recognized cause of circulatory shock. Anemia is not. All right. Have we heard about anemic shock before? All right. It's more of hypovolemic shock. And shock is impaired tissue oxygenation and perfusion. Number two, it's been found that from various studies documented that anemia per se does not compromise tissue oxygenation as long as you are able to maintain the intravascular volume. So the most important thing when we're dealing with blood transfusion anemia in our patient is to first of all ensure that intravascular volume has been replaced, and this will vis-a-vis increase cardiac output. All right. So that is why there are a lot of questions, and this also gives credit or credence to the restrictive blood transfusion strategy. So it's not red cells per se. All right. It's not the oxygen delivered to the tissue that matters, but the oxygen extraction. And more importantly, it is the replacement or maintenance of your intravascular volume that really counts. I hope that makes sense to us. All right. So Rivers and colleagues in 2001, did a study, and we talked about the goal-directed transfusion triggers in the ICU. In fact, if there's anything I want us to take from here, is this idea of what we call goal-directed transfusion triggers in the ICU. All right. So this is a personalized approach to blood transfusion in our patients, and is based on specific goal-directed targets. All right. So the Rivers et al., found out that early goal-directed therapy as relates to blood transfusion resulted in reduced hospital mortality with improved clinical outcomes in patients with severe sepsis and septic shock. The study also showed that this strategy had better hemodynamic stability, reduced organ dysfunction, and resulted in shorter hospital stay. All right. The right of the slides is something for us to ponder about. You have a patient in septic shock with hemoglobin concentration of about 8 grams per DL. What will cause you to transfuse this patient? Will you transfuse this patient or will you not? So instead of taking a decision on the basis of the hemoglobin levels only, that's what we call this early good patient-specific physiological targets. All right, I call it MOSU. All right, this is my mnemonics. I call it MOSU. All right, these are physiological and clinical goals. And there you want to transfuse only if your mean arterial pressure is less than 65 millimeters of mercury, and you have a urine output that is less than 0.5 ml per kg per hour. All right, your venous oxygen saturation is less than 70. Your CVP is less than 8 centimeters of water, and your lactate is more than 2 millimole per liter. And if you are monitoring your entire CO2, if the entire CO2 is less than 25, these are measurable physiological targets that determine your transfusion trigger, not just hemoglobin concentration as a marker or a transfusion trigger. All right, so that is about red cell transfusion. As we move on, we'll talk about platelet. Platelet transfusion is also very common, about 25 to 55% in the ICU. And the platelet usually transfused due to thrombocytopenia, which is defined as platelet count less than 150,000 per macroliter. All right, significant thrombocytopenia refers to a platelet count less than 100. And the incidence, like I mentioned, is about 23 to 35% in ICU. I'm sure many of us would have asked us to transfuse, platelets in the ICU or even in the OR. So, what are the etiologies? Sepsis also comes up, and very, very common, often, overlooked is heparin-induced thrombocytopenia. I like the acronym HEAT. This can hit very hard, especially when you are giving thromboprophylaxis. Your patient is on heparin, and this patient also have thrombocytopenia. So it becomes a clinical dilemma. Should I continue with my thromboprophylaxis, or should I be worried about heparin-induced thrombocytopenia? And we're going to look at it very soon, because the issue with heat, heparin-induced thrombocytopenia, is not of bleeding, it's more of thrombosis. All right. So you want to, you're giving heparin, but the heparin is causing heat. You want to stop. You are exposing your patients to risk of DVT and PE, and this becomes a clinical dilemma. We'll look more into it as we go on. Intravascular coagulopathy, post-transfusion purpura, or patients who have platelet glycoprotein inhibitors, chronic alcohol use, antibiotics, this linozolate and vancomycin. Vancomycin actually can cause immune-related thrombocytopenia. All right, and a lot of times I tell my residents who work with me, vancomycin has a horn. All right, and one of them is this immune-related thrombocytopenia. All right. So we have thrombotic thrombocytopenia purpura. All these are common causes of thrombocytopenia in the ICU. And we need, especially patients where we use vancomycin and linozolate a lot. So what are the indications of platelet transfusion? We can have prophylactics and therapeutic transfusion. All right. In a non-bleeding patient, you may allow your platelet to fall as low as 10. So when it's below 10,000 microliter, you may want to transfuse. For patients with high risk of bleeding, patient sepsis, coagulopathy, when the platelet is, even before the bleeding starts, when the platelet is less than 20, you start. Therapeutic transfusion, especially when your platelet is less than, when there's active bleeding, all right, with the platelet less than 50,000 microliter. Patients undergoing major surgery or invasive procedures with a platelet count less than 50. Patients to undergoing neurosurgery or ocular surgery, you want a higher platelet cutoff, all right, which would be about 100,000 microliter. All right. I don't know how many of us do this. All right. It's common practice to monitor your transfusion, your red cell transfusion response. All right. It's easier. You want to monitor your systemic oxygenation and your HB, but platelets transfusion needs the response needs to be monitored, and there are 3 different ways you do that. You want to measure your platelet count 1 hour and 24 hours post transfusion. And this is to help you to calculate what we call the corrected count increment. All right, the platelet corrected count increment, helps you to determine whether there has been an adequate response, all right, towards your platelet transfusion or otherwise. There's what we call platelet refractoriness, all right, in which case your CCI is less than 7,500 1 hour post transfusion, or less than 4,500, 24 hours post transfusion. It's easy to calculate, all right? The CCI is calculated by platelet increment. What that means is that, maybe you transfuse the patient when the platelet count is about less than 100 or 100, and the post transfusion platelet count is now 400. Your platelet increment will be 400 minus 1 plus the patient's body surface area, and you divide it by the number of platelets that is transfused. So if the CCI is less than 7,500 1 hour post transfusion, you have what we call platelet refractoriness. All right. At 24 hours, if it's less than 4,500, it indicates refractoriness. All right. Other signs, you can use clinical monitors, to observe for signs of bleeding. I remember recently, while a patient with severe tetanus in the ICU, who also developed, severe DIC with a very low platelet count, that we needed to initiate massive blood transfusion for, especially with platelet, and the bleeding stopped. So you could use clinical monitoring, but to be more objective, it's better to calculate your corrected count increment. All right, so I mentioned this heparin-induced thrombocytopenia is common, but it's commonly overlooked. And when we don't look at it, it's potentially life-threatening. It's immune-mediated complication of heparin, all right, and it is caused by, the formation of heparin platelet factor 4 antigen complex. So when this antigen complex develops, the body develops immune response by generating IgG, and this leads to breakdown of your more platelets. All right, it leads to platelet activation, thrombin generation, and can cause vascular thrombosis. And it's paradoxical because you have reduced platelets, and you have thrombocytopenia. The clinical diagnosis of heparin-induced thrombocytopenia are the 40s. You have thrombocytopenia, at least less than 50% reduction in platelet count. You also want to consider the timing of onset. Usually occurs between 5 to 14 days post heparin introduction. All right, you have evidence of thrombosis, your distal DVTs. All right, and when you have ruled out other causes of thrombocytopenia. So you want to do your immunoassays, you want to assay for the HIT antibodies, all right? Be careful that you could have some false positive results, but you should always manage these patients with clinical findings. The timing of onset, when did you start heparin? What kind of heparin did you use? The risk factors, let me go ahead and show you. The risk factor, unfractionated heparin has a higher risk for hemoglobin-induced thrombocytopenia compared to your low molecular weight heparin. And that's good news because we use low molecular weight heparin more for thromboprophylaxis. And patients undergoing orthopedics and cardiac surgery have higher risk of developing heat compared to other medical patients. So clinical features, typically, you'll see more than 50% decrease in platelet count developing 5 to 14 days after first exposure to heparin. All right. And like I mentioned, the major complication is thrombosis, not bleeding. And you'll see thrombosis in the legs in 50%. And this patient can actually through an embolus, all right, having pulmonary embolism. Arterial thrombosis can occur in 5 to 10% of patients. And actually, in about 3 to 5%, this patient may develop thrombotic stroke. All right. So diagnosis requires a positive assay for your IgG against the platelet, heparin platelet factor 4 complex. So what do you do when you have heat in your hands? You want to discontinue heparin, and your patient still requires anticoagulant, so you want to consider alternative anticoagulants. Your directly acting anticoagulants, your agotropan. It depends if you have it, your sender. And don't forget that for the long time, you'll be weary to give this patient heparin because these antibodies can persist in the blood in the body for up to 100 days after exposure. All right, I'm not going to go over transfusion risk. I'm sure we know that this is for academic purpose, but note that transfusion-related acute lung injury is a leading cause of death following blood transfusion. All right, it's similar to ARDS and has an incidence of 1 in 5,000. I don't know if you have had a case where you start blood transfusion and it's part of the clinical scenario we have there. I hope I'm not giving the answers away. Patient suddenly became hypoxic, hypotensive, and immediately after commencement of blood transfusion, that patient had trally and with a very high mortality, actually similar to that of ARDS. All right, transfusion-associated circulatory overload is another very common result, which results in signs and symptoms of excessive fluid in the circulatory system, which occurs within 12 hours after transfusion. So the patient could have dyspnea, you see your B lines on long ultrasound, hypoxemia. You can even have peripheral edema, hypertension, and tachycardia. Citric toxicity because of the calcium chelation that occurs in stored blood may also lead to metabolic disturbances. All right, DIC, I think I need to quickly run so that we discuss our clinical scenarios. DIC is common in ICU. It's associated with 3 C's, all right, clotting, consumptive coagulopathy, and clot lysis. Mnemonics, predisposing factor, disco. All right, so the common causes, predisposing factors. So DIC in our patient, when you have patient with disorders of the vascular system, inflammation of any sort, injury, immunological reactions, gram positive and gram negative sepsis, hemorrhagic fevers, patient with cancers, obstetric patient, especially amniotic fluid embolism, abruption placenta, and eclampsia. These are the common predisposing factors to DIC. All right, you want to look your investigation, clinical features, bleeding from all the orifices and bleeding from puncture sites with evidence of thrombosis. All right, you have thrombocytopenia, your PT and APTT will be prolonged, decreased fibrinogen levels or increased fibrinogen degradation, proteins and or D-dimers. What do? You want to remind me of DIC is DIC. So you want to do the differential diagnosis, what is causing this, because it's important for you to know the cause of DIC. Will it be eclampsia or your amniotic fluid embolism, or could it be due to trauma? All right. Initial resuscitation and stabilization of hemodynamics is crucial. You want to obtain your relevant investigations. And more importantly, you want to correct coagulopathy with your fresh frozen plasma that still has intact clotting factors. All right. You want sometimes, if you're able to assay for the different coagulation factors, you can do specific factor replacement. And desmopressin, all right, the analog of vasopressin, has been found to release your von Willebrand factor and factor 8, all right, mimicking, all right, your cryo precipitate, for the management of this patient. All right. Importantly, there's the DIC score by the International Society on Thrombosis and Hemostasis. All right. And these are the factors on the right side of the screen. A factor of more than 5 is consistent with diagnosis of DIC, and that will help you to ensure prompt diagnosis and prompt management. All right. If you get the slide, you can read this up because of time. All right. So we've talked about transfusion trigger for platelets, platelet transfusion. I think we can read this up ourselves. All right. We've talked about response to transfused platelets. Don't forget your CCI that we mentioned before. Any CCI less than 7,500 in the first hour shows platelet refractoriness. Complications of platelet transfusion, like I mentioned, platelets are stored in room air, so the bacteria flourish more in platelet concentrates compared to your red blood cell concentrates. All right, these are stuff. Massive blood transfusion, yes. This is important. A lot of times we get patients who require massive blood transfusion, all right, and this refers to replacement of a patient's total blood volume within 24 hours. By the time you're giving a patient 4.5 to 5 liters in 24 hours, that qualifies for massive blood transfusion. Or you transfuse more than 10 units of packed red cells in 24 hours. Or you transfuse more than 4 units of red cells in 1 hour. All right, these all qualify for definition transfusion. Indication, remember ghost, all right? Upper lower GI bleeding, obstructive patient, postpartum hemorrhage, surgery, sometimes neurosurgical procedures, trauma, polytrauma, all right, with pelvic and femoral fracture. These are precipitants or indications for implementing massive blood transfusion protocol. All right. So components, early recognition is very important, and you need to activate your MTT by informing the clinical team, the laboratory. Everybody should be aware. And the blood components of massive blood transfusion includes packed red cells, your fresh frozen plasma, platelets, and cryoprecipitate. I like what I wrote here. So cryoprecipitate is rich in fibrinogen factor 8 and von Willebrand factor. So I wrote F8V. All right. So this is the initial thing is to ensure you have balanced transfusion strategy. You want to replace oxygen or increase oxygen carrying capacity. You want to ensure that your patient has enough clotting factors from your fresh frozen plasma and your platelet to ensure proper adequate hemostasis and coagulation. All right. So a lot of times we do 1-1, 1-1, 1-1. There's 1-1. Your packed red cell, fresh frozen plasma, and platelet. Now, that is not enough. You need to also institute adjuvant therapies, your antifibrinolytic, tranexamic acid, all right, must be started. In fact, there was a study that showed it some years ago that instituting tranexamic acid within the first 3 hours of trauma improved survival in patients requiring massive blood transfusion. All right, make sure you warm your fluids to prevent hypoxemia. All right, so this is just the protocol that may be shared with us later on so that we don't. Monitoring is important. You want to monitor and therefore complications of massive blood transfusion. And these are blood conservation strategies. I felt I should bring it in because we're also anesthetists. Because of our time, we may not be able to delve into that as we should. All right, so this is the end, and we'll go back to our clinical scenarios for discussion. And if there are other questions, we are free to ask. All right, have you been hearing me?
Yes, Prof.
Yes, sir. Yes, sir.
Okay, so let's go to our clinical scenarios now. So let's look at the first clinical scenarios. And first clinical scenario and see. Okay, so let's look at the first clinical scenario, and I want volunteers. It's a case-based discussion. You have a 45-year-old female patient with history of breast cancer who has been undergoing chemotherapy. She was admitted with fever, hypotension, and signs of sepsis. On examination, she has petechial hemorrhages, ecchymosis, and is oozing from different sides. Now she has had altered mental status, low GCS, and is in respiratory distress. Laboratory investigation shows that the platelet is 40,000 macroliter, prolonged protobentan, prolonged APTT, prolonged fibrinogen, and it has elevated D-dimer. So the first question is, what's your diagnosis? And what is giving the diagnosis away? Can we have anybody trying?
PE.
You can mute and let's have you.
Okay, let me try.
Please, if you are not talking, can we? Yeah, that's the crash study for the tranexamic acid. Thank you. Please, can you just put off your video? Douglas FA, please. Put off your video. Thank you. So who is trying?
Okay, let me try. Let me see. I think from the young lady's history of breast cancer, chemotherapy, and sepsis, and then with the respiratory distress, and I should be thinking about well, D-dimer, anything can cause that. It doesn't mean anything. This is a patient I want to do CTPA for because I'll be suspecting pulmonary embolism.
Okay. We lost you.
Sorry, I said I will be my first suspicion here. Can you hear me now?
Yeah, I can hear you now, yes.
Yeah, I said my first suspicion will be pulmonary embolism. So I would love to order a CTPA. Of course, the fibrinogen, is low. I mean, the platelets are low. You may think about consumptive coagulopathy if there's any bleed, or again, from all those things.
This
But I
patient
think
is bleeding. He has petechial hemorrhages and ecchymosis, and is oozing from one culture side.
So the patient is bleeding. Is part of is part of the, but at the same time, you can also suspect. That's what I'm saying. You think about consumptive coagulopathy and also think about PE. These are my two differentials.
Yeah. Thank you, Dr. Solomon. Does anybody have a different thing? What will be your primary diagnosis? What will you? Yes, the patient most likely, DIC will have thrombotic components, so this patient could throw an embolus. But Dr. Likwa, sorry if I'm misspelling or mispronouncing your name, it said that DIC is most likely. Can you buttress on that, Doc? A lot of people are saying DIC.
Yes, hello. So this mother has this patient has a history of chemotherapy, as we have seen, and there is also signs of sepsis. And from the laboratory results, as we have seen, there is a prolongation of these coagulation profiles and low platelet number. And the most important finding, the D-dimer is elevated. So it looks that consumption coagulopathy, mainly the DIC, she high likely have disseminated intravascular coagulopathy. Following that, this bleeding diathesis comes. It looks like that.
Okay, thank you very much. Thank you. Yeah, so we will think about DIC. Obviously, we will not rule out PE. There's nothing stopping this patient from trying ambulance. So how will you approach the management of this patient? Your primary thought process is going towards DIC. So how will you approach this management? Any other person wants to talk? I saw one Bridget mention something. Dr. Chahilu, can you say something? Is that patient has GIC? Dr. Chahilu.
Hello.
Hello, yes.
You can hear me?
Yeah, we can hear you.
So yeah, of course, the patient has. I was thinking, the patient has DIC because he has the predisposing factor. So what I'll do, of course, you want to investigate, but there have already been the investigations there. So you have to correct the coagulopathy. You might need to ask for your FFPs or your factor replacement like cryoprecipitate. And if the patient is bleeding, maybe you need blood. Let me see. Mostly you need to transfuse platelets. You might need to give FFPs and also blood, maybe RBCs if you need to.
Okay. Thank you, Dr. Sorry, I hope I'm pronouncing it right. Please, can you correct me the pronunciation? Chahilu?
Chahilu.
Chahilu.
Yeah.
My apologies.
Yeah.
All
It's
right.
okay.
Thank you so much. You're on the right track. But don't forget, number one, you want to, like I mentioned on the DIC slide, you want to go systematically. You want to find out what is precipitating this DIC. All right. And then you want to resuscitate, initial resuscitation and hemodynamic stability. You collect your coagulopathy and beautiful. Thank you. That is the way to go. All right, so let's go to the second one. A 32-year-old female patient presented with severe PPH following an emergency cesarean section, has an estimated blood loss of 2.5 liters. And the presentation, she was hypotensive, tachycardic, and she was pale. So how will you approach the management of this patient? Can someone try? Anybody make an attempt? Can you unmute yourself if you're talking? Hello? Nobody's making any attempt? Do I assume we want to let that one pass? Yes, Dr.
No.
Lake. Yes, please go ahead.
Okay. Hello, thank you. This is Dr. Subalo. So as we have seen on the presentation of this mother, she is presented with the most acute bleeding. As we have seen from the presentation, maybe even we may need to activate the massive transfusion protocol. But as a first, we need to initiate the management with at least fluid replacement therapy, especially at least 1 to 2 liters of crystalloid should be given. We need to secure wide bore IV lines, and we need to give also tranexamic acid because we need to control further bleeding. And we have to take a sample for cross-match, and we need to activate the massive transfusion protocol because, as we have seen from the vital signs, this 2.5 liters, it is an acute bleeding causing this vital sign regimen, hypotension, tachycardia, and pallor. So we have to act very fast, and we need to control the bleeding as well.
Yes, thank you, thank you. So this is postpartum hemorrhage, all right? And that we're forming a team to start obstetric critical care. This is a classical example. Thank you. I think you're on the right. You're on the right. Does anybody have any addition or anything to say to that? I can see some comments on the sessions. We'll discuss that, especially the Red Cross slogan and the river study, Dr. Solomon said is an outlier. Yes, it's open for discussion. All right. So any other, I think Dr. Yusabali Lake has given us that. So let's look at the third one because that's the essence of this. Okay, so a 68-year-old male patient with history of peptic ulcer disease and hypertension, admitted with history of Melena stool hematemesis, presented with hypotension, tachycardia, pallor, HB of 6.5 gram per DL, and there's evidence of ongoing bleeding. So, anyone, how will you manage this patient? First of all, what are we dealing with here?
GI bleeding.
GI bleeding, correct? GI bleeding. So how will you proceed with the management of this patient? Is that Dr. Chahilu again?
Yes. Hello.
Yeah, hello.
So,
please go ahead.
So this patient is presenting with the presentation is almost similar to the last patient. It's an acute bleeding because now we have evidence of ongoing bleeding, and the patient already has a HB of 6.5. So my management, of course, you have to you follow the ABC protocol of managing of this patient. So make sure, of course, your patient breathing airway is okay. And then now when you come to circulation, you might you start replenishing your volume. You make sure your volume is being replenished, but this patient will also need blood transfusion. So you'll give you tranexamic acid if you need to, and then now you take your samples and now look for blood products. Probably you are going to give your RBCs. You might need to give your basically volume. So you have to give your blood RBCs and maybe FFPs and platelets, but you will have now done your full your investigations to see what you need.
Thank you very much, Dr. Chahilo. Thank you. Correct. You're right. Dr. Solomon, why? Your hand is up. You have the floor.
Okay, thank you, sir. I can't feel thanking you enough for these things you are doing for us. Like I told you last time, I'm a fan, so I try not to miss your lecture. So I think while I agree with the approach of the ABCD, of course that's important in an emergency like this, but I don't think that I'm just different a little bit, that blood transfusion is the next thing you do, because this is upper GI. Okay, this is Manila. Sorry, yeah, peptic ulcer. So upper GI bleeding. So you want to do your Blatchford score, the pre-endoscopy score, to see what will happen. Then probably you do endoscopy for this patient, because the endoscopy, apart from giving you the exact diagnosis, whether it is a peptic ulcer causing that or probably varicose veins, you can also deliver the therapy to stop the bleeding from there. Then of course, that's when thereafter you want to replenish the blood. So that's just the little difference I have.
Yeah, thank you very much. Thank you. Eze Chidebere wrote something here. Can you unmute and say something? It's difficult to follow all the chats, but thank you, Dr. Solomon. Thank you, Dr. Chahilu. The most important thing here now is to resuscitate fluid and blood. Then we look at the cause of the bleeding, endoscopic and all that. Beautiful, correct stuff. And we just go to the last one, looking at time. This 60-year-old female patient with history of COPD, admitted with severe anemia due to GI bleed, her HB 6 gram per DL, transfused with 2 units of packed red blood cell. During the second unit, patient developed acute respiratory distress with hypoxemia, and bilateral pulmonary infiltrated on chest X-ray. So, who takes a shot at this patient? Is that a new hand, Dr. Solomon?
Sorry, I forgot to bring down my hand, but I think this one, since I'm here, let me just try it, and any other person can add. And this could be a complication from the transfusion, probably lung injury, transfusion associated lung injury. So that's what I think here.
Yeah. Salah, yes. I thought I saw Salah. Salah something, Salah Jetrubi. Can you say something? I think I saw you mention something.
Hello. Good evening, everyone.
Hello, yes.
Yes.
Yeah,
so,
we can hear you, Salah.
Yeah, so from the case presentation, just as in your presentation, we're dealing with one of the complications of transfusion, which is TRALI, transfusion-acquired lung injury, based on the fact that it's this onset of resp distress, hypoxemia, and pulmonary infiltrates. So management principle will be taking over the respiratory system and managing as ARDS. You also have to be able to stop the transfusion, take it back for group and cross match, and any other supportive treatment that would help with the TRALI.
Yes, correct. So this is most likely a transfusion-related acute lung injury. Yes, and then let me ask us a question. This is a common question I ask during the exams, especially postgraduate exam. In ARDS or TRALI, or patients will have any form of hypoxia, especially if you are ventilating this patient. How do you improve oxygenation without necessarily increasing your FiO2? Anybody? How do you improve oxygenation without increasing your fractional inspired oxygen? Well, I see that a lot of people, when your patient is hypoxemic, take the FiO2 to 100%.
You can increase the PEEP. The PEEP.
Yeah. You can increase PEEP. Number one, that's good. I agree with you. Any other? Somebody, Chris mentioned Felipe. This must be one of my people because this is Felipe. This is my mnemonics. Chris, I think Chris Lowe, please, can you expatiate on Felipe?
Hi, Prof. So
Hi,
Philip
Chris,
is
yes.
a mnemonic. Philip is a mnemonic for increasing oxygenation without increasing FiO2. So P is PEEP, H is high frequency oscillatory ventilation, I is inverse ratio ventilation, and then L is low tidal volumes, I is inhaled nitric oxide, P is prone position, and E is ECMO, extracorporeal membrane oxygenation.
Yes, thank you, Chris Lowe. Yeah, so this is a mnemonic I developed, and I think is very important, especially with this management of this TRALI, to try to improve oxygenation without having to increase FiO2. Thank you so much. We'll spend almost 1 hour, 30 minutes. Yes, Dr. Solomon, and there are some other comments. Somebody was arguing with, somebody said they agree with Red Cross. Come, let's talk. You agree with Red Cross, you said blood cells save life, not blood volume.
Prof, why I said so is that because I think the Red Cross deals mostly with all these emergencies, acute, trauma that has to do with hemorrhage. And in hemorrhage, the pathophysiology is a little bit different, such that blood is the main thing there. Not because when you have acute hemorrhage, you don't want to give plain fluids, no matter what it is, be it plasmolyte or Hartmann's or Ringer's, especially that abnormal saline. No, you want to give blood because that is what the patient is losing because of the pathophysiology. You know, you want to maintain that distance, because giving any other thing, any volume, like if you want to increase the cardiac output, of course, which does improve oxygen delivery, you are going to cause dilutional, what they call it? Coagulopathy, yes, you know, which will worsen the patient's case, and then can also cause more bleeding. You know, so because there are times that you really don't want to give so much volume, because you don't want to, because the more volume you give, if the bleeding is ongoing, then the more problem you cause. So that's why, you know, hypotensive or permissive hypotension is used in such trauma cases. So I do believe that in that case, blood does save lives. And there are a lot of studies that have shown, you know, even pre-hospitally now in some countries like Norway, especially the Scandinavian countries, they are actually using either whole blood or blood products pre-hospitally, because of the difference that different studies have shown that this makes as compared to conventional plasma expanders. Thank you, sir.
Yes, thank you. Thank you, Dr. Solomon. Does anybody have anything to say before I respond to that? Because we're dealing with physiology. We're dealing with going back to basics. All right. Like I mentioned before, in acute hemorrhage, when we have what's it called? You know, massive blood loss and all that. I do agree with you that blood cells is important, but in terms of preventing tissue hypoperfusion and systemic, improving systemic oxygenation, we need to, balance things out, because especially in the ICU, I agree pre-hospital, I agree when you have, acute hemorrhage, maybe in the emergency and all that. But more importantly, is for us to understand the need to improve cardiac output, because anemia, which is reduction in effective hemoglobin concentration, does not impair tissue oxygenation. If you look at the formula, in physiology, so anemia itself has little effect on tissue oxygenation, because in as much as your transfusion will increase tissue oxygen delivery, it has nothing to do with oxygen extraction. But I agree with you, in pre-hospital setting, emergency setting, maybe yes, but that is why it's important for us to balance things out, to know that in as much as blood cells are important, but blood volume, increasing and maintaining intravascular blood volume is more important, especially in ensuring that your patient does not have impaired tissue perfusion. And so that will be the take. And the reverse study, you did say it was an outlier, but that is the basis for most of the restrictive blood transfusion strategy that we use, because most authors, let me just bring this down maybe to help you to decide what you want to say next. Most authors found out that, at HB of 7 grams per dl, there's maximum oxygen extraction. The normal oxygen extraction, like I mentioned, is about 20 to 35%, but there's maximum oxygen extraction when you have low hemoglobin concentration. And that is what happens there. All right. So it's critically important for us. And that's what we're talking about, oligo-directed therapy, when we're talking about using oxygen extraction as a marker of transfusion trigger. Yes, Dr. Solomon, you may take it up from there.
Okay, so thank you so much. I get you. It's always exciting. So, why I remember this topic so because I had this argument, I think about 2 or 3 years ago concerning this, and I remember this article, this Rivers article. I think it was published around 2001, and that informed
2001.
the guideline. That is the sepsis guideline that time. Surviving sepsis guideline of 2003 or 4 thereabout. And it was just one study. And what happened? Why I'm saying it's an outlier is that the early goal-directed therapy of that time, surviving sepsis of that time, based its recommendation on that study. But if you can recall that it was later abandoned, such that in 2016, when the surviving sepsis 3 protocols were released, the early goal-directed therapy was abandoned because that time they were targeting, they are targeting a CVP of between 8 and 12. That's the goal-directed therapy, giving fluids to get a CVP of between 8 and 12 centimeters of water. And if I can remember, and then a central venous saturation of greater than 65%. That makes it look that
70%,
that one size fits all, which found out. So later on, I think in 2010, 2014, thereabout, and then in 2019, there were 3 studies that came out. One was ARISE. ARISE was the Australasian study, published in Australia. PROMISE was the North American study. And there's another one, if I can remember what it was. I can't remember it exactly. Process. These 3 studies.
I remember process study,
Yes. So these studies are trying to repeat exactly what Rivers et al. Did. And they found out that there was no difference. I think that informed the subsequent guidelines that came out following that they have to abandon this early goal-directed therapy. That's why I said the Rivers study is an outlier, because everybody started wondering how could they have achieved the result they got, because nobody, their result is not repeatable, and that calls into question the reliability of that study. So that's all I have to say, Prof. Thank you, sir.
Thank you very much, Dr. Solomon. Thank you. Dr. Sally Jetuk, I like what you wrote here. He said there are also other landmark studies about transfusion triggers, the triple code, the tracks, and all that, and I think he said, I think the biggest problem we have is a perception of fear of seeing a low HB and wanting to transfuse. Blood transfusion should be individualized. I agree with you. And individualizing blood transfusion means that we're not going to just base our transfusion trigger on absolute HB concentration values. All right, there should be other things. And, like what Dr. Solomon said, there's no one size fits all. Each patient should be individualized, and we should have objective parameters to monitor this transfusion, the response to our transfusion. Thank you very much. I think, I don't know if anybody has any other thing to say. We've just spent 1 hour, 30 minutes, but I like the discussion. Sally has also written something. Can you say something? Sally, I like to hear voice. I may not be able to read everything.
Hello. Yeah, Sally Getugi.
Yes,
here.
Dr. Sally, yes.
Yes, I think this is something it's a presentation in one of our conferences regarding transfusion triggers. And at least what you've told today, the take home is 11.5 objectives of transfusion, not just that
Oh my dear sister, you are breaking. We barely can hear you, or is it me? Your volume, your audio is breaking.
Hello. Can you hear me?
Yes, I can hear you
Hello?
now, but your audio was breaking.
Sorry, I think it's a problem with network. I'm saying that I did a presentation about, I'm saying I did a presentation about transfusion triggers, and some of the landmark studies is what you've mentioned about the TRICU, the one for neonates. Even a landmark study where even in neonates from what have restrictive and liberal therapies, of which the restrictive therapy was at a HB of 7. And again, waiting for a neonate to have a HB of 7 is a perception issue, but our ICU patients and their anemia is related to so many issues, and that blood transfusion should be used mainly as a resuscitation issue rather than a perception that HB is low. And just as you've said, Prof, that we need to have objective measures of why we're transfusing. Have we dealt with the cause first?
Yeah.
And then now we can see the way forward. Because there are other therapies that you can do, such as the nutritional supplements, iron supplements, and then seeing if the patient actually has another underlying cause rather than just transfusing. Because one problem that we have is blood is not available easily. So we should also be have the same thing we do with fluid stewardship. Even with blood transfusions, we also need to have a level of stewardship, making sure we transfuse who really needs to be transfused.
Yeah, thank you very much, Dr. Saleh, for that elucidation, elaboration. All right, I really like this discussion because it's bringing different perspectives to the study, and I'm sure that most of our trainees will be able to synthesize their own thoughts and practice based on this different engagement. I think we need to stop here because it's past the hour long time ago. I want to thank you, Dr. Mashava. Thank you so much for your support as the registrar for Canesa. Thank you so much for the support. If you are still here, we would like to just hear your voice and thank you for all you do.
Thank you, sir. Thank you. God bless you for what you are doing. Please keep on doing that for us. We appreciate it. Have a good night and a good week.
Most welcome. Thank you, Prof. Toby.
Thank you, Dr. Mashava. Thank you, Dr. Solomon. Thank you, everybody. Dr. Chihalo, Dr. Saleh, everyone that typed. I may not be able to have read everything, but thank you. And do have a wonderful evening and wonderful weekend. Hopefully, by God's grace, we'll meet again next week. Thank you, and have a wonderful rest.
Thank you,
Bye.
sir.